So we're talking today about emergency airway management. So principally about patients who are not having a crash airway, but need to be intubated. So let's just take a look at the things you need in order to intubate. This is sort of the bare minimum right here. So this is the endotracheal tube, okay? So the size will depend on the size of the patient. Generally for a woman, 7.5, man, and 8. If they're really big, maybe an 8.5. Into that needs to go a stylet. Okay, this is really floppy without anything in it, so you have to have a stylet. Once this tube gets placed, there's a little balloon here that gets blown up, so you need a syringe attached to it, a 10 cc syringe to go along with it. To help it slide down easier, a little surgical lube, okay? So those are bare minimum right there. You also need to be prepared for after the fact. This is a end-tidal CO2 nasal cannula. This helps to tell you if the patient is metabolizing their oxygen and producing carbon dioxide. It's a way to know if gas exchange is happening in the lungs. So this is going to be really important on the patient. Once you have the tube in place, this is the inline one, okay, that then attaches to the tube to help you know that the tube is in the right location. Before you get to that stage, once the tube is initially placed, we use this color change version of this. This is not as good as this inline one, but you'll see a color change from yellow to purple. Okay, it fits right on the end of the tube there. This is something we also need to have on hand. It's pretty quick. For afterwards, we're going to need to put in an oral gastric tube. You can just feed this right down the mouth afterwards, and this will help decompress the stomach where there's going to be a lot of air built up. Other basic things that you need is you need to have discussed and have a backup plan in place. A lot of clinicians will want a bougie. This is a bougie, okay? Sometimes called a gum elastic bougie. It's long, has a little hook on the end. This is if you can't actually visualize the vocal cords, you can use this to aim more anteriorly. Also, if you have a really narrow airway, it's helpful. And it gives you a little bit of tactile. So this is a rescue device. This right here is an eye gel, okay? This is what the outside looks like. This is what we call a supraglottic airway. It doesn't go through the cords, it just sits above. And you can deliver oxygen through here. This is a rescue device and not a definitive airway. We hope we don't have to use this, but we have it available if we need to. You're going to need something to secure the tube in place. We do have tube holders. I don't have one here. Tape will do in a pinch. Other things that you have to have would include an ambu bag, right? Hooked up to an oxygen source. Other sort of mandatory equipment, suction preferably too, hooked up, ready to go, and confirmed that it's on. This is a common pitfall in intubating. You're going to need your monitor, okay? So cardiac monitor on, a reliable pulse ox, and a blood pressure cycling every 1 to 2 minutes. And we need really good IV access. If you don't have good IV access, this is a great time to use your skills and put in an IO. You can definitely give intubating meds through the IO. Speaking of meds, you're going to need medications for what we call induction in order to prepare people for intubation. It's going to consist of a sedative, usually a sedative followed by a paralytic. These are the paralytic agents right here in this box. The two we have here are succinylcholine and rocuronium. Okay. And they're refrigerated, right, guys? Yep. And then we're also going to need medications for after the patient's intubated, right? Can you imagine waking up and having this tube shoved down your throat? So we're going to need to know in advance what we're going to use. So whether it's propofol or some other medication to sedate the patient and provide analgesia. So it's a good discussion to have in advance. Other things that we want to have nearby, the ventilator, and we'll go over this in a few minutes. The glide scope, which you'll find that some providers actually start with, and we'll take a look at that if you want to come over here. The glide scope needs to be plugged in, has an on button, looks like an on button. It's a video intubating equipment. This is the glide scope itself. Pulls out here. It has to be used with one of these covers, so it goes inside the cover. And the tube that you use will need this special stylet in it that makes a really big curve in order to fit the angle of the glide scope. So in order to use this, it needs to be on. You need this special stylet in your tube, and you need this cover for the glide scope itself. So just check with the clinician. They may want to start with this, or they may want to start with traditional laryngoscopy and intubation. Last thing you need is the difficult airway cart. This should always be nearby. This contains some other rescue devices, most notably a Crike kit, which looks like this, and this is a surgical airway right through the cricothyroid membrane in the anterior neck. We hopefully won't have to do this. But if we do, it's nice to splash some betadine on there first, and if there's time to put a little lidocaine in there, that's a bonus too. But this is when things have really become an emergency. So this is the Crike kit right here. So some people will ask you just to have it out and available if needed. Some people, if it looks like it's a really difficult intubation, may ask you to go ahead and open it and just have it ready. Okay. Okay, so we're almost ready to intubate our patient. So we've done a couple things first. We've prepared the patient. So if it's appropriate and possible to obtain consent, we've done that. We've checked to see if they have any false teeth. We're going to leave them in for now, but we just want to know if they're there. Okay, we've decided on our medications, and here we are. What's going to happen now is I'm going to prepare my tube and my intubating equipment, which I'll show you in a second, while Rosemary takes some steps to prepare the patient. So she's going to make sure that they're on the cardiac monitor, they have a blood pressure cuff, a pulse ox that's working well for us, and that they are, right now that we have our end-tidal CO2 monitoring hooked up to our monitor here. I'll show you that in a second as well. And we're going to put the patient on a non-rebreather mask. And the reason we're going to do this is we're trying to fill their lungs with as much oxygen as possible. We're trying to replace any nitrogen that's in there from breathing room air with oxygen, which will give them a nice big reservoir of oxygen for that period of time when they're not breathing on their own and I'm trying to get a tube down their throat. So, so we're going to get them on this non-rebreather, preferably for at least 3 minutes if we can. Their sats aren't going up with this. We may consider putting them on BiPAP or CPAP for a short period of time, or doing a little bit of assisted ventilations with a bag valve mask. You want your oxygen cranked all the way up when you're doing this, because you want to really fill these lungs with oxygen. So Rosemary, you would be checking and making sure that we're monitored and ready to go. So I'm going to go ahead and prep this tube and show you what I do. So this is my tube. It's really floppy. This is a balloon on the end that eventually will get blown up in order to block the trachea. So I'm going to take this stylet. It's bendable. Okay. I'm going to load it in this tube, and depending on the size of the tube, it may be longer than the tube itself. This is pointy. We don't want that to be there. We're going to pull it back a little bit, and I'm going to put a little bend in the top of the tube. And then, you know, everybody's preference is a little different on the shape that they like. I like a little hockey puck on the end like that, like so. So what I'm going to do next is I'm going to test the balloon, and then put some air in this syringe, my 10 cc syringe, hook it to the end, and just make sure that that balloon blows up. And in fact it does. And we don't need it to be totally full of air. Tracheas aren't actually that big, but we just want to make sure that it's going to work. And then we're going to leave that syringe attached to the tube. No, actually we're going to take it off. We're going to be ready to use it when the time comes. I'm going to take some Surgilube, okay, and I'm just going to do it lightly because Fred over here is pretty lubed up already. We're going to add a little swab of it to the bottom of this tube just so it goes down a little bit more easily. I'm going to know where my bougie is. I'm going to know where my color change CO2 detector is and where my tube securing device is. And then I'm going to check to make sure that we're ready to go. Are we ready to go? Excellent. And I want you to notice that through all this, Fred has remained in the upright position. Lungs do a better job of gas exchange when they're upright than when you're supine. So if possible, you want to keep your patient up as long as possible. You'll also notice that there's a little towel roll ready to go back here. Just depending on the body habitus of the patient, sometimes it's helpful to get them in the right position to put a towel behind their shoulders. We can do this after the patient is sedated and paralyzed, but it's nice to have one of these available in case we need it. So we're going to test and make sure that our suction is on and working. That's a key step. Common pitfall, and we're going to make sure we have all of our equipment. Our vent is here, our rescue devices are here, and I think we're ready to go. Yeah? Ready to go? Okay. So we're going to take a little quick pause, and we're going to show you our end-tidal CO2 detector. Lauren's going to demonstrate that to you before we go on to actually do the intubation.
Alright, so we're going to talk about end tidal waveform capnography. It can be used for pre-intubation and with intubation. So you have a nasal cannula that is used with pre-intubation, and you have what's called inline capnography, which is used when you intubate somebody. They both connect the same way up here. They just screw in, pull this down. You can see the threads, and it screws in gently. No need to pull, no need to crank on it, otherwise you can break the machine. Goes in like any standard nasal cannula, can use it like any standard nasal cannula. Hooks up to oxygen using standard oxygen tubing. There are different waveforms that you can see. And what it basically is showing you is the gas exchange that is happening in the lungs. So I'm just going to breathe for a minute. So that is about the box waveform that you want to see. It's not going to really show it as I talk. But it shows your inspiration and your expiratory. Your number that you want is in between 35 and 45. That is your textbook number range. And it can show you all sorts of things. It can show you if you're having bronchospasms, where the box form looks like a shark fin. It's also called loss of plateau. It can show you when your patient is breathing on their own after paralytics, because it'll be a nice box, and then you'll get kind of like a nick and then back in, and that's just showing the diaphragm is starting to move and the paralytics are wearing off. So let's see if I can give you guys a couple good box forms so you know what to look for.
So Lauren, how can that help me tell that I've intubated the patient correctly and that I have not accidentally intubated their esophagus?
So, as you can see, nice regular pattern. That only happens, no matter what the number is or the amplitude on the grid, that only happens when you are placed in the trachea. That's where gas exchange occurs. Gas exchange does not occur in the esophagus or the stomach. You may get like a really, really low number, but normally that will not happen. When you see a nice uniform, even boxing, that you know you're breathing in, you're breathing out. And that's basically end tidal in a nutshell. If you know what normal looks like, then you'll know this is different, something is going on.
Okay, so Rosemary and I have talked about the medications that we're going to use. In this case, we're going to use etomidate and succinylcholine, which you'll often hear referred to as SUX, as in that sucks, and propofol for sedation afterwards. So Rosemary's going to get those medications prepared. And while she's doing that, I'm going to do a final check on my equipment. And I'm going to choose my, my laryngoscope blade. So this comes in two parts. This is how I actually get the tube in. So there's a handle, which has a battery in it, and a blade, which has a light source on it. There's two kinds. They come in straight and curved. This is a Miller and this is a Mac. And they come, as you can see, in various sizes. I prefer using a Mac. Some people prefer a Miller. It can lift up the epiglottis. I'm always going to check and make sure that my light works. And this is the position that it will be in. After the intubation is done, sometimes we forget to close them down. If you see them open, you can go ahead and close it to save that bulb for us. Okay, so Rosemary, do we have medications ready to go?
Ready to go.
Okay, and we have good access, a good pulse ox, patients on the non-rebreather. We have the end tidal CO2 hooked up, and it's going to be ready to go on oxygen at greater than 15 liters a minute. I think we're ready to go. Any questions before we start? No? All right, and Lauren, if things, if I can't get this in easily, I may ask you for the bougie, and then my next step would be the glide scope. Okay? All right, cool. So what we're going to do is we're going to go ahead and get our patient lying down. And we're going to pull them up towards the head of the bed. And you may need to adjust the bed height. I'm not very tall, but some people need to. So we're going to pull the patient up. I'm going to adjust my towel roll. Okay, so Rosemary, we're going to go ahead. Let's go ahead and give him the etomidate, and then we'll switch him out here. So we're going to assume he's 70 kilos. We're going to give Fred 20 of etomidate, please.
All right.
All right, so he's now.
Etomidate given.
Etomidate given. Okay. All right, so yep, it looks like he's pretty sleepy. Let's go ahead and give the succinylcholine. We're going to give him 100 milligrams of succinylcholine. And I'm going to go ahead and switch him out. And respiratory therapist Lauren, would you mind being ready with the ambu bag, which we put somewhere? Perfect. So I'm actually going to put this on under the ambu bag, okay? Because I want this in place when I actually do my intubation. Sometimes this little nasal thing gets in the way. You can always tuck that under. You can even cut that off if you want. All right, so go ahead and we'll be ready on that. All right, go ahead and give the succinylcholine. You can go ahead and give him a little oxygen there. You want to get him as oxygenated as possible. All right. 100 of succinylcholine, please.
100 of succinylcholine in.
Okay, great. Succinylcholine does this funny thing which makes your muscles fasciculate when it works. So I see the fasciculations and I know my patient's ready to go. Okay, so Rosemary, you'll be watching the monitor for me. All right, Lauren, do you want to, this may be on the wrong side, don't we? That's all right, I'll grab my stuff. It's really helpful to have someone to hand me the tube, and when I ask for the tube, I want it in the same orientation I'm going to put it in. I tend to hold it like a pencil, and I want it to be stuck in my hand this way, because I'm trying to keep my eyes on the cord, so it's really helpful if you can hand it to me like this. Thanks, Lauren. Okay, all right, we're ready to go. Let's take a look. I'm going to have you remove the bag. All right, and so I'm going to take a look at Fred. Rosemary's watching the monitor. Lauren's helping me. This guy is very difficult to see. There we go. All right, so I see cords. Can I get a little cricoid pressure, please? Yeah, so that means pushing down right there, kind of on that, right below the Adam's apple to try to move the cords. There we go. Now I have a good look there. All right, hand me the tube, please. All right. Oh man, I'm having a hard time getting it in. This airway's really anterior. How am I doing, Rosemary, with the SAT?
SATs are fine, but blood pressure is dropping.
Okay, so let's get some, have one of our colleagues get some Levophed ready to go. Okay, so I'm going to use this bougie to help me. So Lauren did a really smart thing. She handed me the bougie in the position I'm going to use it with this little hockey stick pointing up. Because I want that to be able, I want to be able to feel that run over the tracheal rings. That helps me. So I'm going to go ahead and put it in here. Can release that cricoid pressure, please. Thank you. Oh, now I feel it. Now, Lauren's done another smart thing. She's taken the stylet out of the tube because we don't need it at this point. It's going to slide right over this bougie. So if you're using a bougie, you want to take the stylet out. All right, we're going to take this out. Then we're going to blow this up here. We're going to give a couple puffs with that ambu bag. Lauren's going to get that out. And if you'll notice it, can you show them the purple? Right now it's purple, okay? When we have it in place in a real live human being who isn't Fred, it's going to turn yellow for us once we've successfully intubated. It's not changing color because Fred isn't actually breathing. Okay, but we're also looking, there you go, there's the yellow color. Smart. All right. So now we're going to go ahead and put the inline on just so we can monitor it. See, there's my light left on. I'm going to collapse that. We're going to go ahead and bag again. We're going to look for that nice waveform we saw earlier. I'm also going to use my eyes and look in this tube and see, is there condensation in this tube? Or are there gastric contents in the tube? And then the last thing I'm going to do is either myself or someone else is going to listen. Rosemary, do you want to listen for me? Over both lungs and the belly. Good, Fred's breathing. So we're going to listen for sounds over both lungs. And then finally the belly, right over the stomach. We don't want to hear gurgling over the stomach. And he's not actually real size. So we want to hear roughly equal breath sounds on both sides. One of the things that can go wrong is that if you put your tube too deep, you can end up in the right mainstem bronchus, and then you won't really hear lung sounds on the left. If you're in the esophagus, you won't hear much in the lungs, you'll hear gurgling in the belly. And then our last method of confirmation will be with a chest x-ray. Now, someone's going to keep bagging and kind of hold this tube in place while Lauren gets it secured, either with a tube holder or with tape. And then, Rosemary, can you go ahead and get the propofol going?
Yes.
And we'll show you that in a minute. Because we want to be prepared to give this person some sedation. Sometimes it takes a minute to get all that up and running, so we might give a dose of Versed or some other medication in the meantime, just so that they don't wake up with a tube down their throat, which would be awfully uncomfortable. All right, so we've got our tube secured, and in a minute we're going to put them on the vent while we start working on our propofol. And it looks like the blood pressure has improved, but if it hadn't, we would have considered either starting a pressor or potentially giving him a dose of push-dose epinephrine. Okay, so a few things to keep in mind. During our little scenario, we did not inflate the balloon on this, and we need to do that as soon as you get the tube in place. You want to inflate the balloon. So if you're handing things to the intubator, handing them the syringe primed and ready to go with some air in it is helpful. So we've got the balloon inflated. The other thing is that this tube has centimeter markings on the side. You're going to be somewhere around 20 to 22 centimeters in most standard size adults. Basically, wherever you land is where you want to keep it, as long as we show that it's in the right place. So you want to make a note of where it is at the lip. So how many centimeters at the lip, and we should record that. The last thing that came up is what would have happened if, when I asked Rosemary, is the patient doing okay, if she told me that the patient's sats were dropping. After you get below 88-90%, you're going to have a real precipitous drop in the patient's sats, and you really don't have much more time. It means that that oxygen reservoir has been used up, and you're falling off what's called the oxygen dissociation curve. And so what we need to do at that point is, if you're really close to getting that tube in place, your provider might proceed and go ahead and secure the tube and get the airway, or we might pause, use our ambient bag, which is going to be hooked up to high flow oxygen, give the patient some breaths, give them time to refill those lungs with air before we start over again with a second attempt. At that point, we might switch to a different modality, for example, the glide scope, or have some other way of approaching the airway so that we can be more successful.
All right. We are using propofol as our medication after our patient has been intubated. This is a sedative. Our starting range is going to be anywhere from 25 to 75 micrograms per kilogram per minute. As Dr. Kimbrell pointed out, this is going to drop his blood pressure, so we're going to want to cycle our blood pressures and keep an eye on that. As you see, this is coming in a glass vial. After we pop the top, we can spike it on our pump tubing. In order for the tubing to work well, there's a release cap here that is going to allow air to be drawn into the tubing so that it can be primed all the way. That has to be open for this to go through, and then we can set the whole thing up on our pump here.
Okay, so we are going to go over the Flight 60 flight medical vent very basically. If you have any other questions, I recommend reaching out to your local friendly RT, plenty of them at the hospital, and they'll be happy to go over this with you. First off, make sure it's plugged in electrically, and make sure it is in an oxygen source. Wall oxygen, not portable oxygen. So you're going to turn it on. And it's going to come up with kind of preset stuff. Your oxygen level, remember, room air is 21%. So depending on what the physician orders based on your patient's condition, you may need to change that. For this example, since my patient isn't real, I'm going to keep it at 21% to save oxygen. Your rate will be as necessary, whether it needs to be quick or slow. You just press it, it turns gold. Change what you need, press enter when that's what you want. You have volume control, which is, as it indicates, is how much volume goes into lungs. Pressure is the pressure that goes to your lungs, and then it takes a breath, inhales, exhales. I keep it on volume control just because it's simple. Go ahead and keep it on SIMV. That's getting more into depth, which you can talk to RT about. PEEP. Your normal PEEP, as you and I talk and breathe, is anywhere from 5 to 7.5, depending on your lung condition. So you can change that as the physician tells you. Again, press the button, change it, push enter where you want it. Because if you just press it, and then you move on to something else, it goes back to what it was already on. Oxygen, if you need only oxygen, you don't even need to bother with that. So when you are ready, your bagger will stop bagging the patient. Alright. We'll go ahead and turn it on and start ventilating your patient. This is going to sing a lot of alarms because, again, this is not a real patient. Maybe it won't. But you're going to watch, make sure your patient has equal lung sounds. Again, reassess. Constantly reassess whenever you mess with the airway. Make sure you have lung sounds on both sides, nothing in the abdomen. And sometimes you'll have a check circuit, low pressure alarm. Basically, you need to check, has my circuit become disconnected? If it has, it will alarm. Is there no oxygen? You'll go through this whole acronym called DOPE, which basically check your equipment. Is there an obstruction? Could my patient have a tension pneumo, which is why you assess the lung sounds each time you mess with them. Other than that, that is a very basic overrun of the ventilator. And there's more alarms that you could potentially see.
Okay, so a couple last things that we need to do. We've gotten our patient on the vent. We're going to have X-ray come and do a portable chest X-ray to help us confirm our tube placement. We're also going to put in an OG tube, which we're going to put a little lube on and just feed down into the esophagus. There's only one hole left for it to go into, so this is pretty easy. Okay, and then we're going to hook it up to some suction. Actually, we're going to first kind of confirm its location. We're going to use a TUMI, listen over the belly first, and then we'll hook it up to some suction, empty out the gastric contents. And now you have an intubated patient.